In this PowerPoint, we're going to take a look at seizures and sleep. Let's get started with our first slide. A seizure is a sudden abnormal discharge of electrical activity of the brain, usually affecting how a person acts or feels for a short time. Known causes of seizures include birth trauma, fever, infection, head trauma, toxins, alcohol or stimulant drugs, medications, brain tumors, stroke, genetics, and anoxia. Let's go on to our next slide. The functions of each lobe of the brain are specific, and the clinical observations indicated above are simplistic and may represent other medical conditions. However, if seizure activity is occurring in any of these parts of the brain, these are the symptoms that are likely or possible to occur. For example, in the parietal lobe, they may have face or upper extremity numbness or twitching. With the occipital lobe, they could have distorted vision or visual hallucinations. If the seizures are occurring in the temporal lobe, they may not be able to respond to auditory stimuli, they may have impaired memory, or they may be in fear. With the frontal lobe, they may have difficulty speaking, they may holler profanities, or they may laugh inappropriately. Let's go on to our next slide. This is just for your information. You don't need to know this, you're not going to be tested on it, but it might help put some of the pieces together. Ictal, this refers to the time during a seizure is occurring. Interictal refers to the time between seizures. Preictal is the time before a seizure, and postictal is the time after a seizure. Let's go on to our next slide. Now these terms you do want to know and have a fair understanding of. A spike is a transient EEG wave with pointed peak and duration of 20 to 70 milliseconds. Polyspikes, these are multiple spike complexes. A sharp wave has the same morphology as a spike, but with a duration of greater than 70 but less than 200 milliseconds. And a spike and slow wave is a spike followed by a high amplitude slow wave. Later in this PowerPoint, you are going to see examples of these. Let's go on to our next slide. Seizure classifications. We have generalized seizures and partial seizures. Generalized event begins with a widespread epileptiform activity over both hemispheres of the brain. It's associated with sudden movement or loss of consciousness. These include the tonic-clonic types of seizures, also called grand mal, absence seizures, also called petit mal, myoclonic, and atonic, which is also referred to as drop attacks. With partial, the event begins as an electrical discharge over a localized area of the brain, one hemisphere only. Let's go on to our next slide. This is an example of a tonic-clonic or grand mal seizure. With these, there's typically no warning. There's a tonic phase where the limbs stiffen. There's loss of consciousness. They may be injured or become injured. They may cry out or groan. During the clonic phase, there's rhythmic jerking. Consciousness returns slowly. In duration, these only last a few minutes. Postictal, they may be confused, tired, agitated, and may complain of a headache or nausea. Their respirations may be absent during the tonic phase and labored during the clonic phase. And these can be tonic only or they can be clonic only. So they can vary slightly. Let's go on to our next slide. The absent seizures, or petit mals, these are most common in children ages 4 to 14. They begin and end abruptly. Usually duration is just a few seconds. Oftentimes they just have a blank stare and look like they're daydreaming. It may be associated with rapid eye blinking, and it can be activated with hyperventilation. Let's go on to our next slide. Myoclonic refers to abnormal brief jerk-like movements involving both sides of the body lasting a second or two. Atonic, or drop attacks. This is complete loss of muscle tone, including falls to the ground, usually associated with injury, and are often noticed by a head drop. These can be confused with cataplexy, which occurs with narcolepsy, which again is why our good sleep history and thorough evaluation of our patient is important. Let's go on to our next slide. Partial seizures can be associated with an aura, and include they can have a bad taste in their mouth, they can have distorted vision, they could have a burning sensation, they may experience deja vu, they may experience headaches, dizziness, just complain of a strange feeling. Let's go on to our next slide. Partial seizures can be further categorized by simple partial or complex partial. With simple partial, they are conscious, their memory is intact, their awareness is preserved, but they may exhibit facial twitching, odd smiling, eye blinking, and have some emotions. With complex partial, at least one of the following is present, either impaired consciousness, memory, or awareness. They'll have a trance-like appearance, and they may exhibit random, undirected movements. Let's go on to our next slide. PNES in the past was known as pseudo-seizures, psychological, or psychosomatic. It is important to recognize many precipitating factors can lead to this diagnosis, including past or present abuse, depression, and mental disorders. Let's go on to our next slide. Sleep and seizure overview. Non-REM. Generalized discharges and clinical seizures mostly occur in non-REM sleep. This is considered a natural convulsive agent because it happens so commonly. The majority of EEG discharges are seen in actually N2 sleep and activates in interictal epileptiform discharges in both partial and generalized syndromes. REM, asynchronous patterns in atonia, is resistant to epileptic EEG potentials. So, in summary, non-REM is most commonly when seizures occur. Let's go on to our next slide. This slide is just telling us that if we have a patient with a known history of epilepsy and they also complain of excessive daytime sleepiness, then we have a few possible causes to consider. One, maybe they're having nocturnal seizure activity. Two, it could be medication side effects. Three, it could be an underlying untreated sleep disorder. It could be poor sleep hygiene, or it could be another medical condition that hasn't been identified yet. Let's go on to our next slide. Types of seizures and conditions where seizures occur. You'll notice on your left-hand column I have all the different types of seizures listed. This isn't all of the types, but this is many, and these are all included in your book. We're not so concerned with the specifics of all of these different types of seizures. I just wanted you to have a very basic idea of what a seizure was, the different classification schemes, as in generalized, focal, and so on. So over in your left-hand column, I'm kind of telling you what's important for you in regards to this topic. Each type or condition of seizures is unique in presentation and occurrence. You as a sleep technologist do not need to identify what happens with each type of seizure or when it's going to happen. For example, does it happen in non-REM sleep? Does it happen with awakening? Does it happen shortly after they fall asleep? You as a sleep tech do not need to know that information. However, as a sleep tech, you do need to be able to recognize spike-wake activity. You do need to know what to do when you observe seizure activity. So let's go on to our next slide. One quick note before we go on. There are similarities between seizures and arousals. They're both abrupt onset. They both can have confusion, disorientation, memory impairment, and they can occur following non-REM or prior to non-REM. So it can be difficult to tell the difference. So again, it's very important for you to be able to recognize the spike and wave activity so you can tell the difference between an arousal and a seizure. Let's go on to our next slide. General guidelines for responding to a seizure. Patient safety is always the number one priority. If epileptiform activity is prolonged or frequent, assess the patient and determine if further interventions are required. There is a balance. Data needs to be recorded to confirm a diagnosis, so keep your machine running. And then follow the protocol specific to your sleep disorder center. Let's go on to our next slide. General guidelines for responding to a clinical seizure. Remain calm and continue recording. Protect the patient from harm. Time how long the seizure lasts. Do not attempt to stop any clonic movements. Do not place objects in the patient's mouth, and stay with the patient. Again, keep your recording going. Do not stop it. Documentation following a clinical seizure. You want to record the date, time, and duration of the occurrence, a description of the event, actions taken by you, notifications that were made. Did you call the doctor? Did you call the family? Vital signs following the event, time it took for baseline level of consciousness to return. Let's go on to the next slide. When to activate EMS. If you have a patient with a seizure lasting longer than 5 minutes, if a second seizure starts soon after the first one has ended, if consciousness does not return after colonic movements have subsided, and any signs of physical distress, injury, or pregnancy. This really comes down to just common sense and logic. If the patient's at danger, you need to activate EMS. Let's go on to our next slide. A few things to remember. Most seizures only last at the most a minute or two. Only in rare cases do they end on their own. Do they not end on their own? You can't stop a seizure, and they are not dangerous to others. So if you can keep these in mind, remember to stay calm, keep your machine running, make observations, and document it once it's over. You'll be fine. Well, now let's go on and let's take a look at some examples here. Okay, our first set of examples are going to be epileptiform discharges during sleep in generalized epilepsy. Okay, so in this example we have a polyspike. This is a typical generalized polyspike in a patient with an idiopathic generalized epilepsy. Note that the discharge is followed by about 2 seconds of delta activity. This after going slow activity indicates substantial disruption of the background is a significant argument to consider this discharge pathologic and not a normal variant. So this is just an example. Notice your paper speed is not at the speed that we record in sleep. This is at EEG recording speed. Let's go on to our next slide. In this example, it's a 3 Hz spike wave complexes. This shows typical 3 Hz spike wave complexes in a patient with an idiopathic generalized epilepsy. This patient likely has absent seizures. If tested with a clicker, a discharge of this duration, which was about 4.5 seconds, is likely associated with a brief impairment of awareness. And again, this is on EEG paper speed. Let's go on to our next slide. Here's an example of our generalized paroxysmal fast activity followed by attenuation in a patient with symptomatic generalized epilepsy of the Lennox-Gastaut type. This could be an interictal discharge, but could also be an ictal pattern associated with tonic-atonic seizures. And again, this is at our EEG paper speed. Notice how you're seeing your spike activity in all of the channels because it's generalized. Let's go on to our next slide. Okay, now we're going to take a look at some examples of epileptiform discharges during sleep in focal epilepsy. So let's get started with our first slide here. Okay, this is a focal seizure involving the temporal lobe, and you can see how you do not see the seizure activity in all of your channels. It's only in your temporal lobes. Let's go on to our next slide. Here is an example of a left frontal spike in a patient with left frontal lobe epilepsy. And on the left-hand side, you see the EEG montage, and on the right-hand side, you see the singular electrodes to a reference electrode. And so you can kind of narrow down where the seizure is occurring. You can see it in your FP1 lead and also your F7 leads. So let's go on to our next slide. Treatment options, again, this is not something that you need to know. I just thought you might like this extra information. You're not going to be tested on this. It's just some additional information for you. Anti-epileptic drugs are the most commonly used to treat seizures. Side effects can include nausea, weight gain, headaches, vision changes, clumsiness, weight loss, and vomiting. Let's go on to our next slide. How the anti-epileptic drugs can affect sleep. This would be more important to us. Generally, the older anti-epileptic drugs decrease your sleep latency, decrease REM sleep, and increase daytime drowsiness. However, the newer drugs appear to have less of an effect on sleep. They may have some increased REM and insomnia. Their effect on daytime sleepiness, though, is still not known. So let's go on to our next slide. These are just a list of your anticonvulsant medications so you can recognize them. Notice Klonopin is actually an anticonvulsant medication, and you guys have probably heard of that being used to treat RLS. So let's go on to our next slide. Again, here are some more anticonvulsant medications. You may recognize Lyrica on that list. And then when you're done, you can move on to your next slide again. Okay, this is just an overview of how seizures are controlled. First of all, they need to follow a treatment plan. They need to maintain regular sleep cycles. They need to avoid stress and then do regular evaluation and follow-up. As you have noticed in previous slides, there is a high correlation between non-REM sleep and seizure activity. So sleep deprivation can worsen seizure activity and have a negative impact on their quality of life. So maintaining a regular sleep schedule is very important. Let's go on to our next slide. General guidelines for seizure montages. Again, this is just some good information to have. You probably aren't going to be tested on it specifically, but you should have a good idea. There is no current mandated montage. So according to the ASM scoring guide, they do not say anywhere in there that these are the leads you need to record for an EEG. Monitoring additional EEG channels can help not only identify IEA, but also define the seizure focus, whether it's generalized or partial, and if it's just in one lobe or not. Additional electrodes commonly utilized to record an abbreviated longitudinal bipolar montage include FP1, FP2, T3, and T4. Let's go on to the next slide. General guidelines for seizure montages continued. Consider using an expanded EEG montage for any patient with a history or diagnosis of epilepsy, anyone with a known cause of seizures with ongoing symptoms, any witnessed rhythmic movements during sleep with nocturnal incontinence or injury, such as tongue biting. Follow all protocols specific to your sleep center and be proactive for the patient. Okay, the next couple of slides are going to show you the difference of epileptiform activity on a 10 versus a 30-second epoch. The previous examples we looked at were on the 10-second epoch, which is the EEG montages, and we're going to see how those are going to look when you're recording at your speed, paper speed for sleep. So let's go on. Okay, so here is a 30-second epoch. So this is what you're going to record in your sleep lab. Notice how your spikes and waves, it kind of looks like artifact, doesn't it? You don't see your chin clenching, but that almost looks like what happens with EEG when someone clenches their chin. Let's go on to our next slide. This is the same epoch slowed down to 10 seconds. And this is a good rule of thumb. If you think that maybe your patient is having a seizure, go ahead and slow down your recording speed to 10 seconds and take a look at it. See if you can see that spike and wave activity. Let's go on to our next slide. Here's a side-by-side comparison. Again, you have your 30-second epoch there on your left. That's what you'd see running your recording at night, and then your 10-second epoch on the right. Let's go on. Okay, and this is our last example. This illustrates the stable background before and after a generalized burst of spike and slow wave activity. So although it sort of looks like teeth clenching, which in your chin you can see it's definitely not teeth clenching, you see there is no arousal before it or after it. So this is purely just seizure activity. This is what it would look like. This concludes this PowerPoint.